Thanks very much, Greg, for that kind introduction. Great pleasure to be here, talk about acute coronary syndromes and a lot of the things we can do now to improve prognosis in patients after admission with an acute coronary syndrome. A number of different disclosures relevant, some of them, to this talk. So one of the sort of key concepts we have now in terms of how we personalize treatment after acute coronary syndrome is because many of our patients get the same treatment, same drug combinations, so 1 year of dual antiplatelet therapy. But we're recognizing increasingly that there's some patients with unmodifiable risk factors who are at higher risk. So here is a nice demonstration from the American guidelines on some of the modifiable risk factors, hypertension, diabetes, sort of semi-modifiable, and some of the other lifestyle issues, but some of the relatively fixed risk factors, including chronic kidney disease, obviously higher age, and a number of other factors, which make patients at sort of long-term increased risk. And this gives us a number of targets that we can pursue in terms of optimizing outcomes after acute coronary syndrome. We've got thrombosis risk, the cause of most acute coronary syndromes, not all, is thrombosis. Related to atherothrombotic disease. We can target lipids, which is the driver of atherothrombosis, blood pressure. Then there's left ventricular dysfunction for the unfortunate patients who develop this or have long-standing dysfunction. We can have many options now in improving outcomes in these patients. And glycemic control, a lot of evidence that we can improve on outcome in diabetes patients. So in terms of thrombosis risk, we've made huge progress in terms of tackling this. This is driven to some extent by our understanding of where the different drugs are working. So aspirin, very effective, very reliable, but it targets a limited part of platelet function, which is why aspirin alone is often insufficient in these ACS patients. P2Y12 receptor on platelets, very successful target. And we have drugs that have different levels of consistency of inhibition of this receptor. And anticoagulants. These obviously tackle the coagulation pathway, but what is not well appreciated is that anticoagulants are also antiplatelet drugs because they indirectly or directly can inhibit thrombin-induced platelet activation. And you can see that if you target all three of these pathways together, as I'll talk about a little bit, you get quite sort of profound inhibition of platelet function as well as coagulation, and that's associated with high bleeding risk. Now, one of the things about clopidogrel being the mainstay of treatment for ACS since the cure results, but has been replaced by more effective drugs, and shown here is a couple of studies we did with ticagrelor. On the left is ticagrelor versus placebo. So placebo in green, and 2 doses of ticagrelor, 60 or 90 milligrams twice a day, pre and post maintenance dose. We can see a very consistent effect of ticagrelor. Then on the right is those 2 ticagrelor doses compared with the same assay against clopidogrel. And if you draw lines across those, you can see there's a huge overlap between what you see with placebo and what you see with clopidogrel. And that's because clopidogrel doesn't work in everybody. And so it's a rather unreliable antiplatelet drug when you come to individualization of therapy. Whereas ticagrelor, because it's not a prodrug, just need it to be absorbed to be effective, and so more consistent antiplatelet effect. And in the Plato trial, that was shown to be significantly better in terms of improving mortality. Observational data, not nearly as reliable as a randomized controlled trial, but gives some comfort if you see the same thing as we saw here in our observational analysis in Sheffield. And one of the sort of big factors with more reliable antiplatelet effect that we've seen is much better prevention of stent thrombosis. And also some of it you'll see here with ticagrelor, still some early stent thrombosis, but we've learned some of the mechanisms of that. And we've got almost as close as we can to abolishing stent thrombosis in patients undergoing PCI. Now, one of the questions is how long should you continue dual antiplatelet therapy? And there's some studies suggesting, particularly in low-risk patients, stopping early before 1 year, which is our sort of fixed in our mind as the sort of duration for everybody. But in the high-risk patients who were put into the Pegasus TIMI-54 study, it's a different issue, and that's because in these patients who are at least a year post-MI, in the placebo group just treated with aspirin, over the course of 3 years, there was a 9% event rate of cardiovascular death, MI, or stroke, and many of them being important events, even if non-fatal. And ticagrelor at one of two doses, 60 or 90 milligrams twice a day, consistently over time reduced the primary endpoint. And this is intention to treat, so not everyone stayed on treatment. And in fact, for most of them, it was the first time that they'd had ticagrelor, and not everyone could tolerate it because of either bleeding or dyspnea. But there was a penalty in terms of, as I say, bleeding. So with ticagrelor 60 milligrams, which is the licensed dose now for long-term treatment, and NICE has approved that for treatment beyond 1 year, we saw increased major bleeding, increased minor bleeding, but reassuringly, no difference in terms of fatal bleeding. So although adding ticagrelor to aspirin gives you much more platelet inhibition, there was no evidence that that was significantly increasing intracranial hemorrhage, and it wasn't increasing the number of deaths due to bleeding. Now, these trials do exclude patients with high bleeding risk, such as prior intracranial hemorrhage, and this study also excluded those with prior ischemic stroke. So not everyone gets into these trials, and so you have to look at that when you're making a decision on individualized treatment. But there is this balance to be struck with long-term treatment. So on the left is number of events, CV death, MI, or stroke prevented with ticagrelor treatment, 10,000 patients over a year. On the right, the increased major bleeding. And it doesn't look that great in terms of net benefit until you consider that on the left, that includes fatality, includes deaths, includes disabling stroke, includes large heart attacks. And on the right, the increase is all in non-fatal bleeding. So if you're focused on survival, you have to accept in these high-risk patients the increased risk of bleeding in order to achieve this mortality reduction. And although CV death was not significantly reduced in the trial overall, there were signals in higher-risk patients of mortality reduction. So particularly when we looked at coronary heart disease-related death, which was an exploratory endpoint. So you have to be cautious when you're sort of drilling down on the data. And the main thing is, does it make sense, the analysis that you're doing? And was the trial showing a significant effect overall, which in this case it was. So multivessel disease and a number of the other high-risk features like peripheral artery disease, chronic kidney disease, they're all sort of unmodifiable risk factors that lead to higher event rates and greater absolute benefit from more intensified antithrombotic treatment. So in terms of how you individualize, we've recently published an algorithm here in patients, and it's relatively conservative in terms of selecting the patients. We just went for the high-risk patients because we appreciate it's challenging for clinicians to sort of balance this bleeding risk versus ischemic risk. So what we've focused on here is the highest risk patients with multivessel, extensive CAD, and an unmodifiable risk factor, diabetes, peripheral arterial disease, chronic kidney disease, but also patients having recurrent MIs despite secondary prevention, or very severe multivessel disease, which is not going to go away. And in these patients, if they tolerated dual antiplatelet therapy, then the other question to ask is, do they have a high-risk bleeding feature? So if they have an indication for oral anticoagulation, then they're a separate group. Or if they've got a history of anemia or spontaneous bleeding, that seemed to sort of neutralize any benefit. But also things that excluded them from the trials, like severe liver disease or extreme old age or frailty or cancer, those sorts of things. You have to ask if there's a high bleeding risk condition there. And if not, then prolonged therapy. So NICE has approved a further 3 years, but in fact it makes no sense to stop at 4 years of 1+3 because these risks don't go away. And there's no evidence that the benefit attenuates over time. So really, we're looking at long-term therapy in patients who can tolerate dual therapy and have this unmodifiable high risk. Now, there is another option, so the COMPASS trial in patients with either prior MI or stable multivessel coronary disease, randomized to aspirin alone, a very low dose of rivaroxaban, 2.5 milligrams twice a day with aspirin, or slightly higher dose of low dose rivaroxaban, 5 milligrams twice a day. And the rivaroxaban plus aspirin, so targeting two different pathways of thrombosis, as with dual antiplatelet therapy, but here an anticoagulant at a very low dose plus aspirin, reducing ischemic events over time in these patients. And in terms of the individual components of the primary endpoint, there was a reduction in CV death, although it didn't meet the pre-specified threshold for significance. Quite a marked reduction in stroke and lesser reduction, numerical reduction in myocardial infarction. So this sort of opens up another option, but really emphasizes the fact that in high-risk patients, aspirin alone is not sufficient. Adding a second antithrombotic drug to aspirin can achieve benefits even though there is an increase in bleeding. There is a particular issue with patients who have both atrial fibrillation and acute coronary syndrome, because on the one hand, we want to treat and prevent further coronary thrombosis, here showing a blocked right coronary artery and the thrombus that was aspirated. And on the left, how do we prevent cardiac thromboembolism? You see there a transesophageal image of left atrial appendage thrombosis, where you've got a low sort of shear sort of blood stasis that we believe is more thrombin-dependent thrombus generation. And so we've got to prevent both of these, and dual antiplatelet therapy is our standard for the left side, and oral anticoagulant therapy our standard for the right. And recent guidance last year from a group that Greg chaired provided some guidance as to how to individualize therapy according to ischemic and bleeding risks. But for most patients, recommending a month of triple antithrombotic therapy, even though we appreciate that that's associated with a high bleeding risk. But since this guidance, we've had the Augusta study, which took patients with either ACS or undergoing PCI or both, and randomized them 2 by 2 to either warfarin or apixaban, 10A inhibitor, and randomized them to either aspirin or placebo. And in the vitamin K antagonist plus aspirin, this was our major or clinically relevant non-major bleeding, over 18%, so very high incidence of bleeding in 6 months. Apixaban versus warfarin reduced that risk. And then if we took away aspirin, just gave warfarin, a much lower risk, and if we just gave apixaban without aspirin, there was the lowest bleeding risk. And all these patients were also on a PTY12 inhibitor, so it was either dual or triple therapy. But this showed how much reduction in bleeding you can get by using a NOAC and not giving aspirin in the early phase after PCI and or ACS. And in terms of secondary outcome, death or hospitalization, very similar rates, but a numerically lower rate with the apixaban and no aspirin group. If we look at ischemic outcomes, there was a bit of an issue in terms of aspirin versus placebo. It wasn't statistically significant, but as you work down these, no difference in terms of stroke rates, but in terms of stent thrombosis, there was numerically more if you use placebo rather than aspirin. And so that raises a bit of a challenge in terms of how we interpret this and individualize therapy from now on. But there are some general principles that we can apply. As Greg said, if the CHAS-VAS score is low, they may not need oral anticoagulant therapy, although, as we've heard from Greg, that coronary artery disease does give you a point now. But looking at the risk of stent thrombosis, which was slowly getting better at predicting stent thrombosis risk, and that has come down with newer stents, so there's been big improvements in stent technology. Need to look at the factors that increase the risk of bleeding. Use a NOAC in preference to warfarin unless there's poor renal function that contraindicates or cautions their use. But now we can stop aspirin early after PCI if stent thrombosis risk is low or if the bleeding risk outweighs the risk of stent thrombosis. But if we're going to use warfarin, it's really important to control the INR carefully more carefully than we normally do in order to avoid peaks in the INR that would really drive a high bleeding risk. So other things beyond thrombosis, we've got lipids, statins, excellent treatment for slowing down this process of atherogenesis, the cause of most ACS events. And statins very powerfully doing that, but not everyone can tolerate them, and those that can don't always achieve as effective reduction as we'd like. And we know from many, many different trials now that the more you bring the LDL cholesterol down, the more you reduce the cardiovascular event rate. So the more reduction, the better. We've learned even more from recent trials of PCSK9 inhibitors, which maintain the LDL receptor expression in the liver to take up the LDL cholesterol, remove it from the plasma. And alirocumab is an example of one of those that profoundly reduces non-HDL cholesterol, shown here, and consistently does so over time with repeated injections. And in the Odyssey outcome study recently shown, alirocumab significantly reduced cardiovascular events, including a reduction in mortality. And interestingly, when a subgroup analysis was done looking at baseline LDL cholesterol level, the benefit was most profound in those who had the higher LDL cholesterol at baseline, 2.59 millimoles per liter or greater. So showing that, and these patients were also treated with statins, a large majority have tolerated. So further LDL cholesterol lowering beyond what we can achieve with tolerated statin therapy is particularly effective in those who aren't achieving sort of target with their oral treatment. But the other thing with these, obviously, there's an affordability issue. PCSK9 inhibitor is very expensive, and so the question is how much we can afford it. But at least we have the evidence now that there is this benefit in those with suboptimal control. Blood pressure, we've heard about some of the issues in terms of blood pressure management in the last talk. There is a move towards more intensive treatment. SPRINT study, which was semi-automated blood pressure monitoring, showing with more intensive treatment of blood pressure we can reduce cardiovascular events. And this has led to sort of tightening up of the recommendations. There's still a bit of controversy because of the method of measuring blood pressure. Clinic blood pressures often are higher than normal resting blood pressure, and so not as reliable a guide to blood pressure control as we would like. And in the ACS, post-ACS population, I'm increasingly using ambulatory blood pressure monitoring. It is very helpful in terms of tightening up control without causing adverse effects in terms of hypotension. Left ventricular dysfunction, I'm not going to go into a lot of detail about this, but there is more that we can do now in terms of managing this. So people may forget aldosterone antagonists with those with heart failure and significant LV dysfunction after ACS. And that's one of the things added to ACE and beta blockers that can improve prognosis, but also devices, cardiac resynchronization therapy, and ICDs in those with LV ejection fraction less than 35%. All these things have improved the outcomes in patients with LV dysfunction and heart failure after ACS. And finally, a little bit about glycemic control, because we know this is important, but some of the trials looking to sort of tighten up control immediately after ACS, like with insulin, have been negative, and partly that's because you've got this adverse impact of hypoglycemia, which sort of offsets some of the benefits of reducing sugar levels. But SGLT2 inhibitors, one of the classes of drugs that have been showing quite a lot of promise in diabetes overall, and of course our ACS population with diabetes, a particularly high risk cohort. And with the multiple potential mechanisms of benefit of SGLT2 inhibitors, we see improvements in cardiovascular outcomes, such as here, the EMPA-REG study, showing evidence of mortality reduction, as well as the primary outcome of cardiovascular events. And hospitalization for heart failure particularly seems to be reduced with this class of drug. And then liraglutide and other GLP-1 agonists also showing cardiovascular benefits. So there is more that we can do for the diabetes population. So just to conclude, addressing modifiable risk factors has a profound effect on prognosis after ACS. We've made huge strides in reducing risk after ACS, but there's more that we can do by adopting evidence-based strategies. That includes long-term dual antithrombotic therapy for patients at high risk if they don't have a high bleeding risk condition, getting LDL cholesterol down as far as we can and as far as we can afford to do is helpful. Blood pressure management, shouldn't lose sight of that and should be fairly carefully individualized. LV dysfunction, important not to forget and not to miss the patients with poor LV ejection fraction who will benefit from device therapy. And the use of new agents needs to be incorporated into post-ACS management in diabetes patients. Thank you very much.